Hello again. Today we're going to talk about labor and delivery complications. We're going to start with premature rupture of membranes, which is a rupture of the amniotic sac and leaking of amniotic fluid beginning at least 1 hour before the onset of labor. Normally what happens is labor starts and that's what causes your membranes to rupture, but the membranes actually rupture before labor starts. And it can happen at any gestational age. We have premature rupture of membranes, and then we have preterm premature rupture of membranes, which is your water breaking before 37 completed weeks of gestation. And this happens in approximately 10% of all preterm births. And it's caused by pathologic weakening of the amniotic sac due to inflammation or stress of contractions, or infection, or any number of things. So we talked about infection. One of the most common infections is chorioamnionitis, and it's an infection of the amniotic cavity and can cause premature rupture of membranes. It's the cause of about 25% of all preterm births, and some of the clinical findings are maternal fever, fetal tachycardia, uterine tenderness, and a foul-smelling fluid. So care for premature rupture of membranes is determined by the mom's risk for developing an infection. Should we induce her now or wait for her to go into labor naturally? If her risk for infection is low, then we can probably wait. If her risk for infection is high, we might not be able to, as in if she's been ruptured for a long time, her risk for infection goes up. We might need to induce her. For preterm premature rupture of membranes, it's the same, but we also take into consideration gestational age. If the baby is very premature and we want to give the baby an opportunity to mature further, then we may hospitalize mom, put her on IV antibiotics, and keep her on bed rest in hopes of keeping her pregnant for longer and trying to push off her actually going into labor. So, preterm labor and delivery. What is it? Well, preterm labor is cervical change and uterine contractions occurring between 20 weeks gestation and 37 weeks gestation. Once we have reached a completed 37 weeks, then it's no longer preterm. Preterm birth is any birth that occurs before the completion of 37 weeks gestation. And the risk factors are listed here. History of spontaneous preterm birth, African American race, they're more at risk. The very old and the very young. If you have any sort of infections, if you have multiple fetuses in your uterus, you having twins or triplets, if you smoke, if you have diabetes, hypertension, obesity, all of these can lead to preterm labor and birth. So can we predict it? Well, we can't really predict it, but we can do tests to rule it out. So there's a test called fetal fibronectin, and we take a vaginal swab to test for a particular enzyme that we know is present when labor starts. So if we see this enzyme, labor may start, but if we don't see this enzyme, then we're certain that labor's not going to start, at least not for 48 hours at least. We can also do a cervical length. As labor starts, the cervix shortens, and we can see this on an ultrasound. What causes this? Infection can cause moms to go into spontaneous labor, and also bleeding. If she has had some sort of trauma, like a motor vehicle accident or a fall or something like that, and there's a little bit of shearing of the placenta from the uterine wall, which can cause some bleeding. Blood is very irritating to the uterine muscle and will actually cause contractions. So care management. We as healthcare providers, we really have no way to prevent preterm birth because we really don't know what exactly causes a woman to go into labor in the first place. We do know that certain factors predispose women to preterm birth, and women can reduce their risk by identifying those factors and reducing them, and we listed some of them on the previous slide. At least the factors that are modifiable. Obviously, your age and ethnicity you can't do anything about, but if you're obese, or if you're sedentary, or if you have diabetes, those things you can modify to a certain extent to help increase your chances of making it to term. Seeing a doctor on a regular basis during your prenatal period goes a long way to helping to identify and reducing those risks. If we could diagnose preterm labor early, then we might be able to put interventions in place to prevent it progressing into preterm birth. So every woman, especially those who have multiple risk factors for preterm births, should be educated on how to recognize signs of preterm labor. And if she comes in, hopefully we might be able to get it stopped. So nursing interventions involve suppressing uterine activity. As I said, we can't really stop delivery, but if we can reduce or stop the contractions, we can reduce the chance of delivery. We also want to be able to get some corticosteroids on board, like betamethasone. That way, if she does go on to deliver prematurely, then the baby's lungs will be a little bit more mature, and his chances of not developing respiratory distress syndrome is greater. Also, it helps to reduce his risk of intraventricular hemorrhage, that's bleeding in the brain, and necrotizing enterocolitis, which means that's where a part of their bowel kind of dies in necrosis. Preterm babies are at risk for a number of things. If preterm birth is inevitable, then what you need to do is support the patient and her partner. This is a very scary time, and they'll be very anxious. We've already discussed what fear and anxiety can do to a patient in a labor, so we want to make sure that we do things to try to keep her calm. You also want to have all necessary equipment and supplies that you'll need there. And you also want to make sure you notify the people that need to be present. Someone there to take care of the baby, someone there to help the mom deliver. You cannot leave the mom if she is actively getting ready to deliver, but call out to somebody and have them call these people for you. Make sure you have someone there for the baby. And babies, premature babies, are at risk for respiratory issues. We know that, so having a respiratory therapist readily available wouldn't be a bad idea either. So now we're going to move on to multiple gestations. Due in part to advances in fertility treatment, the incidence of twins has been on the rise, and having more than one baby in a uterus at any one time has additional risk factors. Miscarriage of one or both, or if you have more than two, all of the babies during pregnancy is a risk. Also, with more pregnancy hormone, you have more incidence of things like maternal hypertensive disorders, gestational hypertension, preeclampsia. More babies means more fluid, so moms are more at risk for developing hydramnios, and we'll get into that as we get further along. They're also at an increased risk for premature rupture of membranes, preterm labor, and placental abruption. Real estate on the inside of the uterus is limited, so the more placentas you have attached to the wall, the more likely one of them is going to attach in a place that it's not supposed to, like over the cervix, which leads to placenta previa. You also have an increased chance of the placentas kind of connecting and growing together. This can lead to twin-to-twin transfusion. Moms of twins are more likely to be anemic. They're more likely to develop a thromboembolism. They're more likely to have a dysfunctional labor and delivery. They're more likely to have a postpartum hemorrhage. So what should we do? Well, we monitor all moms of multiples very closely. More frequent visits, more monitoring, and the mode of monitoring depends on the number of fetuses that she has. If she has twins, we might be able to, if we're lucky and they're close to term, keep both of them on the monitor, but if she has triplets or quadruplets, that's going to be very difficult. And more than likely what will happen is whenever she comes into to the doctor's office, he'll do an ultrasound and actually look at each of the babies. We also need to do lots of teaching about how to care for themselves, how to recognize signs of preterm labor, and we have to teach them what to expect as far as additional monitoring. And all this education just goes to help reduce that anxiety that we've talked about in a few of the lectures. Amniotic fluid embolism, which we now call anaphylactoid syndrome of pregnancy, is a life-threatening condition where a small amount of amniotic fluid enters the maternal circulation through a small tear in the chorion and then potentially travels to the lungs. Fluid embolism usually occurs during labor, but it can occur during a spontaneous abortion, it can occur during an abdominal trauma, an amnioinfusion. Amniotic fluid contains particles of debris, vernix, fetal skin cells, meconium possibly, and when it travels to the lungs, this can cause sudden respiratory distress, acute onset of hypotension, which can quickly develop into complete cardiovascular collapse. So this is really bad news. A woman in the late stages of labor can become increasingly dyspneic and hypotensive. She may experience seizures, which quickly followed by cardiac arrest, massive DIC and hemorrhage, followed by death. Most patients die within an hour of onset, and for those that don't die, 50% will have long-term 50 to 75% will have long-term neurologic deficits. Most of the neonates of these moms will die, and once again, those who don't die will have long-term deficits. We can't predict when it'll happen, so we can't prevent it, but some risk factors such as multiparity, advanced age, placental abruption, placenta previa, preeclampsia, fetal macrosomia, as well as fetal demise are all risk factors. There is some good news. It's not all gloom and doom. Thankfully, anaphylactoid syndrome of pregnancy is very rare, ranging from only 1 to 12 out of 100,000 births. So it's not that common at all, but it makes up about 10% of all maternal deaths. So it is very severe, which is why we are covering it. Now we're going to move on to amniotic fluid issues. Polyhydramnios means having large amounts of fluid, greater than 2,000 milliliters, and occurs in about 1% of pregnancies. Because amniotic fluid is swallowed by the fetus in utero, obstructions of the GI tract can lead to this buildup. Fluid is urinated out by the fetus, so having multiple fetuses in the uterus causes more fluid. Poly is also associated with open neural tube defects and fetal hydrops, which result from fetal anemia. Poly increases mom's risk of respiratory compromise, preterm labor, preterm rupture of membranes, preterm delivery, fetal malposition, macrosomia, or macrosomic babies are also tend to be polyhydramnic, umbilical cord prolapse, placental abruption, and postpartum uterine atony leading to hemorrhage. If the amount of fluid is putting the mother or fetus in jeopardy, then we can do what's called a needle amniotomy, where we insert a needle into mom's uterus and withdraw some of the fluid using a syringe. There's also the other extreme is oligohydramnios, which means having only less than 500 milliliters of fluid, and it's associated with post-maturity, intrauterine growth restriction. We discussed that fluid is urinated out, so if there's renal malformations, you can also have oligo. Fluid is inhaled by the fetus and helps to mature the lungs, so a baby without a whole lot of fluid might have respiratory problems. Fluid helps the baby and the cord float, so with less fluid, you get more compression of the cord, which, as we talked in a previous lecture, will lead to fetal heart rate decelerations. If the fetus can't float, then additional pressure can be put on certain parts of the body, bones and joints, that would form a particular way in a baby that's floating and very buoyant. If they're compressed on that particular area, might not form appropriately. Once the membranes are ruptured, an amnio infusion can be initiated, which can help the baby float and avoid pressure on the cord. And we'll talk more about that in a minute. Meconium stained fluid. So what is it? Meconium means that the fetus has passed what's called a meconium stool before it's born. Meconium can be thick or thin. The fluid is usually greenish color, and it can be the result of a normal physiologic function for a baby that's been in there for a long time, or fetal distress caused by hypoxia or umbilical cord compression. So why is this important? If a baby breathes in this fluid with meconium in it, then the baby is at risk for what's called meconium aspiration syndrome, which can lead to can lead to respiratory distress. So what do? Well, we assess the baby on a delivery, and for babies who are vigorous and crying, then we just suction the mouth and nose and stabilize the infant as we would normally. For babies that are kind of weak and floppy at the delivery, then we do more deep suctioning below the vocal cords using an endotracheal tube. This is done by a physician at delivery. So we as the nurse, what we need to do is we need to have the equipment ready for him to be able to do this. Prolapsed cord. A prolapsed cord is when the cord comes down into the pelvis in front of the fetal head. As the head descends, pressure is placed on the cord, and the vessels within the cord that bring oxygen to the baby get kinked, and if the pressure is not relieved, then the fetus will die. This is a medical emergency. Some risks that are associated with having a cord prolapse are polyhydramnios, early rupture of membranes before the fetal head is engaged in the pelvis, fetal malpresentation. The fetal head fits kind of nicely in the pelvis and it's kind of a tight fit, nothing's going to get around it, but if there's anything other than a head down there, fluid can pass by and the cord can get flushed out with the fluid. A fetus who's small for gestational age or one that has an abnormally long cord can also be at risk for this. Nursing interventions involve assessing the fetal heart rate immediately after the membranes are ruptured or as soon as you discover the membranes are ruptured. And if fetal bradycardia is noted, then you have to rule out a cord prolapse. If there is a prolapse, then what you would do is you would put your fingers inside the vagina and push up on the presenting part to get the pressure off the cord immediately. So here's some pictures of how you would do this. You can place your fingers in the vagina and push up the presenting part. Or if the mother is able, you can ask her to get into a knee-chest position. The baby will fall out of the pelvis, and hopefully the pressure on the cord will be relieved. And of course you need to monitor the baby while you're doing this. Once the pressure is removed, you should see the fetal heart rate come back and stabilize. If you guys remember veal chop from the previous lecture, cord compression leads to variable decelerations in the fetal heart rate. So once the pressure is removed, the fetal heart rate should return to baseline and stabilize. Now we're going to move on to dysfunctional labor patterns. You may also remember this from the fetal monitoring lecture. Contractions are like Goldilocks and the Three Bears. They have to be just right. Hypertonicity or tachysystole is how we term it now, is when the uterus contracts 5 or more times in a 10-minute window, averaged over 30 minutes. Contractions in early labor can be very irregular and kind of uncoordinated. So you may have 5 contractions in the first 10 minutes, but then only 2 for the next 2 10-minute windows. So when you've averaged over 30 minutes, you don't have tachysystole. Other forms of tachysystole are contractions that last longer than 2 minutes, or a firm resting tone in between contractions. Nursing interventions include monitoring contractions and changing mom's position, offering comfort measures. If oxytocin is running, then decrease the rate or turn it off altogether. Give mom extra fluids and oxygen. And if you have a doctor's order, then you might give some tributaline to relax the uterine muscle. some examples of tachysystole can be found in your book on page 424. A hypotonic labor pattern is when you have too few contractions, so you have fewer than 2 to 3 contractions in a 10-minute window. Uterine contractions of low intensity that are usually irregular don't allow labor to progress and don't produce cervical change. So labor is drawn out, which increases the chance of infection. So some nursing interventions is to monitor contractions closely, evaluate cervical change. You may perform an amniotomy or give some oxytocin to get the contractions coming stronger and closer together. With both of these conditions, you would evaluate the fetal heart rate, keep track of the mom's vital signs, monitor for infection, keep vaginal exams to a minimum. We do want to know if the cervix is changing, but we don't want to introduce infection, and support the patient with teaching and, of course, answering her questions. So here is the example of the hypertonic or tachysystolic pattern found on page 424. On the top, you see a normal labor pattern. On the bottom, it doesn't look like there's a whole lot going on, but all those little bumps and lumps are little tiny, well, they might not be tiny, they're contractions, and without internal monitors, we really can't determine how strong they are. If this is an external monitor, then all we can do is count frequency, and it looks like she's having them pretty close together here. So now we're going to move on to precipitous labor and birth. What is precipitous labor? It means that the entire labor and birth occurs within 3 hours from start to finish. A precipitous labor is not a mom that's been laboring at home for hours and comes in and delivers very quickly after she arrives. It means from the onset of labor to a delivery is within 3 hours. So how does precipitous labor affect mom? Well, contractions are often very, very strong and painful and very close together. The patient may feel completely overwhelmed. There's not really a whole lot of time for her to adjust. There's very little time to get her any sort of pain relief if she desires that. The patient may have an abruption due to these contractions because they're so strong and so fast. She might have a laceration to her cervix or her vagina or her perineum because the birth happens so fast the tissue doesn't have time to stretch. The mother's more at risk for a postpartum hemorrhage, and women who have several babies are more at risk for a precipitous delivery. So for those of you that watch reality TV and know Mrs. Duggar, what's that show called, 19 and Counting or something? She would be one at high risk for precipitous delivery and birth, and if I was her labor nurse, I'd be watching her like a hawk. So how does precipitous labor affect the fetus? Well, it's very stressful. These contractions are very strong and very close together, so they might pass meconium, which might lead to mech aspiration. All that pressure on the fetal head from moving through the pelvis so fast can actually cause intracranial trauma. So some of the nursing interventions would be to watch these patients very closely if you know they have a history of precipitous delivery. Have a precipitous pack available. Stay with the patient. I know you'll want to run for the hills when you hear her like she's getting ready to start delivering, but stay with her. Have someone else call the doctor and the pediatric provider. Keep her calm, help her breathe, and if she feels like she wants to push, encourage her to pant and blow. Monitor the baby and roll her onto her side. This will help slow down the delivery. Don't attempt to stop the baby from coming out, but if the baby does start to crown, you can apply gentle pressure to the presenting part to keep it from popping out and tearing her perineum. Hopefully with these interventions, the panting and the blowing and the rolling her to her side, you'll be able to slow down the delivery long enough for a provider to get there. But if not, and the baby delivers, then suction out the mouth and nose and dry him off and stabilize him as you would normally. You can see pages 387 and 388 in your textbook for more specifics about how to care for these moms. Now we're moving on to post-term pregnancy. Post-term is defined as a pregnancy that lasts 42 weeks or longer. This is very uncommon in this country, as most women receive medical care during their pregnancy, and if their due date has come and gone, their doctor will quickly schedule them for an induction. Because carrying a pregnancy to 42 weeks, there's some risks involved. Some of the risks are an increased incidence of a baby who's very large or large for gestational age, or a macrosomic baby, which can lead to perineal, vaginal, and cervical trauma. It could also lead to the birth having to have forceps or a vacuum. It can also lead to increased risk of hemorrhage. Fetal risks include placental circulation problems and a decrease in amniotic fluid, which could lead to those variable fetal heart rate accelerations we talked about earlier. If the baby is a macrosomic, then there's more risk for birth trauma, shoulder dystocia, meconium aspiration. I think I said that already. Some nursing interventions are to do kick counts, because after 40 weeks the placental perfusion decreases some, and you want to make sure the baby's still getting enough to sustain himself. Plus, you would want to do a non-stress test and maybe a biophysical profile to look at the baby and make sure that they're doing all right. If these tests are unfavorable, or the fluid starts to go down, then the patient will probably be scheduled for an induction. Fetal malposition. We'll start with persistent occiput posterior position, because this is the most common form. If you remember from the labor processes presentation, the fetus should be delivered in the occiput anterior position, ideally, which means that the occiput, or the back of the fetal head, is towards mom's front and the baby is facing towards mom's back. This position allows the greatest amount of flexion of the neck, so that the fetus can get up and under that pubic bone and come out. If the fetus is facing mom's front and the occiput is towards mom's back, then there's not as much flexion that's going to be able to be done by the fetal neck. The occiput posterior position, the fetus can't maneuver as easily underneath that pubic bone. Mom typically complains of intense back pain with contractions. The baby may deliver this way, or it may rotate spontaneously, or it may need to be rotated by a provider with forceps in order to have it be able to come out. Or mom might be able to get it to rotate herself if she changes position. Some of the positions that you can help mom assume to rotate the baby include moving from side to side, back and forth, getting her into the knee-chest position or hands and knees position, pelvic rocking. And if the baby turns, then the second stage of labor usually goes pretty fast after that. So be ready. Some other malpresentations are listed in your text with diagrams on page 430. They are brow, where the forehead presents first instead of the occiput. The head is slightly extended. Medical interventions are typically not done unless labor is slowed or other problems occur. And it may occur, there's a more likely risk of perineal trauma. So the mom will have more tears. The baby may sustain cerebral or neck compression, which can damage the fetal trachea or larynx. There's also a face presentation where the fetal head is hyperextended. This happens most frequently in multiples. Preterm birth, or a baby who's anencephalic, where part of the brain is missing, and so therefore the fetal head is kind of malformed. The risk of cephalopelvic disproportion and prolonged labor is increased with this position. The fetus will display facial swelling and may have little petechiae or ecchymosis on the face, which is bruising. If labor is effective and the chin is anterior, the fetus can deliver vaginally, and there's a picture of what that looks like on page 431. If the chin is posterior, it can get hung up on the sacrum, which will require a C-section, and there's a diagram of that on page 432. Breech is when the head is not the presenting part at all. The head is somewhere up in the fundus. And we discussed breech positions a little bit in the labor processes presentation, but there's different types of breech, but all of them involve the head being up in the fundus. This is more common in preemies than in term babies, and there's an increased risk of cord prolapse because, once again, the head fits very nicely. Anything else other than the head is going to allow fluid to escape, which the cord, being lighter than the baby, might get flushed out first. The head has no time to mold during the vaginal birth, and so if you are able to get the body out, the head will usually become trapped. The head is the biggest part. C-section is usually common if an external cephalic version is not successful, and we'll talk about what that is a little later. If vaginal delivery is attempted and the head does get hung up, you want to have some Piper forceps available, which you see there in the picture. The body's out, the head is still in, and the Piper forceps are going to help tuck that chin so that the head can slide out. There's also what's called a shoulder presentation, and this requires a C-section if you can't get the baby to turn, because basically the baby is laying sideways and there's absolutely no way that it's gonna fit out. And if you do a C-section, you might have to do a vertical C-section instead of a horizontal cut in order to make more room. There's an increased risk of rupture of the uterus and an increased risk of cord prolapse if the membranes actually rupture while the baby is laying this way. There's also something called a compound presentation, where you have two parts emerging at the same time. For example, the head, and maybe the baby has his hand up by his head, and as the baby starts to crown, you see a head and then you see some little fingers. Most compound presentations resolve on their own, but some will require some manipulation at birth. So I said we were going to talk about versions, so here we go. An external cephalic version. This is a procedure that may be performed if there's a breech or a shoulder presentation, and basically the baby is turned from the outside to hopefully a head down position. There's two types of versions actually. There's the external cephalic version, if successful, will allow the patient to deliver vaginally instead of having a C-section. And there's also something called an internal version, which is not very common at all. It's also called a podalic version, and it's performed when you have one twin that's cephalic or head down and delivers, and the second twin might be breech or shoulder or something. Once the first twin's out of the way, the doctor can actually reach up into the uterus and turn the second twin so that it will come out head first. This procedure is a lot less common than it used to be, because now we just normally schedule the mom for a C-section if they're not both head down. An external cephalic version is done if the woman is not done if a woman is unlikely to deliver vaginally. So if there's uterine malformations or a previous C-section with a vertical scar, or fetal conditions like placenta previa, or something that would prevent her from delivering vaginally anyway, then there's no point in doing a version. Some risk factors, there are a few for women, but most of them involve the fetus, because as they're being turned around in there, they might actually, the cord might become entangled or compressed, or the placenta might be sheared a little bit from the uterine wall. The mom's blood and the baby's blood might be mixed, and if she's Rh negative, then this could cause some problems. So usually moms who are Rh negative will get something called RhoGAM before we do a version. And we always need to be ready to do a C-section, because if something happens, if we go manipulating the baby and all of a sudden the fetus starts showing signs of distress, we have to be ready to go back to a C-section immediately. An NST is done prior to the procedure. The version is performed at a location and time when emergency delivery can be performed. It's usually attempted after 36 weeks, once again, because if we have to go back for a C-section, we need a baby that's mature enough to live outside of the uterus. The mom is given tocolytics to help relax the uterus, so the version will be easier to do. And she may be given an epidural to reduce pain, because it's not a comfortable procedure. Ultrasound is used to guide, so the doctor can kind of see how the baby is facing and how he needs to turn, and also to help monitor the heart. About every 2 minutes they can look at the beating heart and see how fast it's going. Some nursing considerations provide lots of information and to help reduce anxiety. Assess mom's vital signs every 5 minutes along with the fetal heart rate pattern before the procedure, and then after, of course, we aren't going to have the fetal monitor on while the doctor is manipulating the baby. Have an IV line in place in case we have to rush back for a C-section. Observe the mom for 1 hour after the procedure and keep a close eye on the fetal heart rate pattern, mom's vital signs, and look for any contractions or leaking of fluid. So here's a picture of what an external cephalic version might look like. So the baby is head up first, and the doctor just kind of moves it around until it gets to a head down position. So moving on to macrosomia. Macrosomia is defined as a fetus that is greater than 4,500 grams. This is slightly different than what we said earlier, large for gestational age, or LGA. If a baby is 34 weeks and is 3,600 grams, that's large for gestational age, but doesn't technically meet the criteria for macrosomia. This condition is most common in pregnancies that are complicated by obesity, excessive weight gain, gestational diabetes, post-maturity, or sometimes moms might just have a history of having big babies, or mom might have been a big baby herself. And also male babies tend to have more of an increased risk than female babies for being macrosomic. Some complications of having a macrosomic baby are shoulder dystocia, operative vaginal delivery, which means forceps or vacuum, or C-section, dysfunctional labor, long labor, which could lead to a postpartum hemorrhage and infection. So nursing interventions are to identify factors that put mom at risk and to monitor for dysfunctional labor. So shoulder dystocia, what is it? We talked about it with the macrosomic baby. Basically what happens is the head is delivered, but the rest of the body cannot get out. Usually it's because the anterior shoulder is stuck underneath the pubic bone. That pubic arch might be a little bit too narrow. What are the possible effects on the baby? They can have birth injuries, what's called a brachial plexus, as those nerves in the neck and shoulder get injured. Moms are at increased risk for hemorrhage and rectal injuries. If a shoulder dystocia occurs, what needs to happen is the nurse needs to perform a McRoberts, and I'll show you what that looks like in a different slide, and pubic pressure. The provider may need to extend or do an episiotomy. He or she might also need to perform several other maneuvers, like a wood screw maneuver, or potentially fracture the baby's clavicle to get it out. Change mom's position, or there's also something called Zavanelli's, which is pretty much a last-ditch effort. That's where the doctor pushes the baby back in order to do a C-section. This is very dangerous, and very few babies survive to this point. So for babies who have a dystocia, what you want to look for at once they come out are signs of a fractured clavicle, signs of a facial palsy, or other CNS issues due to damage to those nerves in the neck and shoulder. So here's what a shoulder dystocia looks like. The anterior shoulder is trapped, as you can see, underneath that pubic bone. Here's McRoberts, which is basically means that we pull mom's knees almost back to her shoulders, and that helps to straighten out and widen that pelvic arch. Suprapubic pressure is when you push, you put pressure on the back of the shoulder in an attempt to turn the baby slightly so that the shoulder will slip underneath that pubic bone. For the first few years as a labor and delivery nurse, every picture I saw, it looked like they were pushing straight down. So that's what I was doing. And it wasn't until I had been doing it for a while that someone actually showed me, you're not trying to crunch down on the baby's shoulder, you're just trying to turn the baby slightly. The pubic bone is just right there in the front, it's not along the sides. And sometimes as baby's coming out, that pelvic outlet is wider from side to side than it is from top to bottom. So if you turn the baby a little bit, you might be able to get the pubic bone, or get the shoulder out of the way of the pubic bone, and the baby will be able to come out. There's also something called a Gaskin maneuver. This is that change in position we were talking about. You use gravity to help you. So basically, you turn mom over, the shoulder will drop just enough for the doctor to be able to deliver the posterior shoulder, and then there'll be more room for the anterior shoulder to fit through the birth canal. Now let's move on from dystocia to uterine rupture. This is a life-threatening condition for mom and baby. The uterus is extremely vascular, and the mom can lose pretty much all her blood volume out of her uterus if she's close to term. The most frequent causes are a scarred uterus from a previous C-section or surgery. Some signs are abnormal fetal heart tracings, a loss of fetal station, which means the head is going up instead of down into the pelvis, and that could mean because the baby's body is protruding out the top of the uterus. Also severe abdominal pain, and you'll see signs of shock, a high pulse, and a low blood pressure. Moms who are at increased risk are moms who've had multiple C-sections and no previous vaginal deliveries. Moms who are being augmented or induced, their labor is being induced. Moms who are carrying multiples. Moms who have a macrosomic baby. Moms who have an infection. Or moms who have short intervals in between several babies. They're at more of an increased risk. Now let's move to complications in the third and fourth stage of labor, starting with retained placenta. A placenta is considered retained if it's been 30 minutes beyond birth and the placenta is still attached. This can result in excessive bleeding and might require a manual or a surgical removal, which can of course increase mom's risk for infection. Other complications you may see is an accreta, which is where the chorionic villi of the placenta actually grow into and penetrate the myometrium of the uterus. And that placenta is not coming off, and it's going to have to be surgically removed. And depending on the extent of the penetration, mom might actually have to have a hysterectomy. And the biggest problem with these accretas is hemorrhage. And lastly, lacerations of the cervix, perineum, vagina, and we can detect these by seeing bright red bleeding even with a contracted uterus. And once again, moms can lose a lot of blood this way, so we have to be on the lookout. Here's a chart showing you the different degrees of laceration. First degree involves only the vaginal mucosa, and it's really not that big a deal. It's uncomfortable, but it's not going to cause any lasting issues. Second degree extends into the subcutaneous tissue, and it's a little bit more painful but can still be repaired. Third degree extends all the way down to the rectal sphincter, and here's where we maybe might start having some problems. And fourth degree actually goes all the way through the rectal sphincter, so there's no more division between the vaginal opening and the rectal opening. This requires a lot of repair, and moms have a considerable amount of problems. Okay, so now let's move on to cervical ripening. Let's actually get into the actual process of birth. Cervical ripening is done to soften and efface the cervix that is not already favorable prior to inducing. So we don't want to keep contracting the baby down into a little hard, green apple cervix. So if the cervix is soft and effaced, then it'll dilate more easily. In order to determine if the cervix is in need of ripening, we do what's called a Bishop score. The higher the score, the more successful the chance of going into labor. So, and you can see a chart on that on page 451 in your textbook. If we do need to do some cervical ripening, the two most common medications are Cervidil and Cytotec. And you can read more about these medications on page 451. Cervidil is a vaginal insert, and one of the advantages of that is that it can be pulled out if baby starts having some issues or the uterus starts contracting too frequently. Contraindications to cervical ripening in general are any conditions where a vaginal delivery would also be contraindicated, like too many previous C-sections or uterine scars, active herpes infection, cord prolapse, or placenta previa. You can see page 452 for any additional contraindications to labor, and page 451 for contraindications to Cytotec specifically. And some nursing implications are if we give this, we always have to observe for tachysystole, observe for fetal distress. Keep mom lying down initially, or else, the cervical ripening agent might fall out if she gets up and starts walking around. And if tachysystole does occur, then turn mom to her left side, give her oxygen, give her some fluids, and if it's Cervidil, then pull it out. So now that we've ripened the cervix, we can move on to labor. So we'll talk about induction. Why do we induce? Well, moms may have a medical condition that requires them to end their pregnancy, like worsening preeclampsia. The only cure for preeclampsia is delivery, so if it starts to get really bad, we might have to end this pregnancy sooner than maybe we would like. Or the fetus might not be tolerating life inside the uterus and might do better on the outside. You can see page 452 for a list of other conditions. First, we have to determine if the cervix is favorable. We kind of already talked about that with a Bishop score. If the Bishop score is too low, we'll have to do a ripening agent. Methods to induce might be stripping of membranes, which is basically separating the amniotic membrane from the inside of the lower uterine segment. And this releases prostaglandins, which soften the cervix and can cause some contractions. This is not a comfortable procedure. It will cause some cramping and some bloody discharge. But if it's successful, then labor will begin within 24 to 48 hours. There's also mechanical dilation, and that's where we place a balloon inside the cervix and then blow it up with normal saline. And it stretches and it mechanically opens the cervix, which also softens the cervix as well. And then we have oxytocin, which is given IV, and it's titrated until we get at least 3 to 4 contractions that last about 40 to 60 seconds in a 10-minute window. PIT, or oxytocin, is always infused in a secondary line piggybacked into the port closest to the IV catheter. And you can read more about Pitocin on page 453 and 454. You always want to monitor for tachysystole, though, and look at the fetal heart rate pattern and watch out for a potentially rapid birth. We kind of already talked about what happens if the baby comes out too quickly. So here's a diagram that kind of depicts all the things that can happen when we are doing an induction. You might get stronger, more frequent contractions, which can lead to more pain and fatigue. There's also a requirement for continuous fetal monitoring while you're infusing the oxytocin, which limits mobility, and then there has an antidiuretic effect, which can cause water intoxication. So it's not anything to be toyed with. Okay, so once we have mom in a good labor pattern after her cervix is ripened and she's been induced and she's contracting regularly, and the head is, or the presenting part, hopefully the head is engaged, then we might want to break her water, which is called an amniotomy, or artificial rupture of membranes. In order to do this, the patient needs to be at least 2 centimeters dilated, and the presenting part, i.e. the head, has to be engaged. Advantages are contractions are similar to spontaneous labor, so there's virtually no risk of tachysystole if it's performed alone. If you give it with oxytocin or something else, then the risk is that of having someone on oxytocin. It doesn't require any additional monitoring, once again, unless oxytocin is running. And you can also look at the fluid to make sure it's clear and that there's no meconium. The disadvantages are birth needs to occur within 24 hours or the risk of infection goes up. So once you've broken someone's water, you've committed them to delivery. There's no turning back. We can't turn the pit off and send her home. There's also a danger for prolapse cord if we break her water before the head is engaged. Some nursing considerations are to assess dilation, effacement, and station, position, and fetal heart rate before the procedure. Monitor the fetus after the procedure, paying close attention to the color and the amount and the odor of the fluid. The head should be engaged to avoid prolapse. I want to monitor for abruptio placenta, which can occur due to rapid decompression of the uterus. We want to monitor for amniotic fluid embolism, which can happen with also that rapid decompression. A small amount of fluid can accidentally get pushed up into mom's circulation. We also want to monitor temperature every 2 hours so we can determine if mom's developing an infection. So here are ways that the provider can rupture someone's water. There's something called an amnio hook, which is there at the top, or there's also something called a digital amniotomy device, which is a little kind of thing you see at the bottom that looks like a little piece of a glove with a little barb or a hook on the end. And here's a diagram depicting all the things that can happen with amniotomy. These procedures should never be considered routine. There's lots of things that can go wrong. Everything that has an action has a reaction, and we can have more head compression, we can have more cord compression, we can have risk for infection. So we always want to make sure that whatever we're doing, there's a reason to do it, and we just don't do things because. One of the things that may happen due to breaking someone's water is they might lose too much fluid, which can lead to those variable decelerations that we talked about before. So variables, as we know, are due to cord compression, and moms can have them either they had fluid and now they've lost it, a lot of it, or they might have had oligo, which means they didn't have that much to begin with. In either case, how we fix it is we try to change mom's position, but if that doesn't work, we can perform what's called an amnio infusion. This is where we infuse warm sterile saline, or LR, into the uterus using an intrauterine pressure catheter. Some of the contraindications are infection, placenta previa, or abruptio placenta. Some nursing considerations are to monitor vital signs frequently, monitor the fetal heart rate and contractions, ensure the patient is comfortable, and change her pads regularly. Once we start pushing fluid in, we want that fluid to come out, and so she's going to be wet all the time, so be sure that we're changing her pads. And speaking of fluid coming out, make sure that it is coming out. If it's not, then we can actually induce hypertonus by overinflating the uterus, which would be a bad thing. Now we're getting close to delivery, so let's talk about episiotomy. An episiotomy is a surgical incision to enlarge the vaginal opening. Routine performance of this is not recommended, but the procedure is not uncommon. You may see it if we want to reduce the pressure on a head of a small or a preterm baby, or if there's a macrosomic baby and we're concerned about dystocia, or if we need to insert forceps or a vacuum. Some risks include infection and pain. Some nursing considerations is we want to hopefully try to prevent an episiotomy. Pushing in the lithotomy position is probably the worst way to push. I know you guys, we're going to see that a lot, but all that pressure is put on that little perineum, that little piece of skin between the vaginal opening and the rectal opening. Pushing in an upright position or a sideline position actually helps to promote gradual stretching of the perineum. Natural pushing is better than coached pushing. We talked about open glottis versus closed glottis pushing already. Warm compresses can also help that skin to soften and stretch. And a gradual controlled fetal descent and expulsion of the head can help, once again, that tissue stretch so it doesn't tear, and we don't require an episiotomy. Aftercare means that we're assessing the perineum regularly. We're observing for signs of hematoma. We're observing for signs of edema. Cold compresses for 20 to 30 minutes and then removed for 30 minutes is very helpful in the first 12 to 24 hours. Moms will really appreciate you if you offer them some ice. So here are the different methods of episiotomy. A is medial lateral, kind of that cut to the side, which doesn't extend into the rectum as easily, but it also, you're cutting into more muscle and more tissue, and there's more bleeding and more pain. If we cut straight down, which is B, which is a midline, that there's less muscle, less tissue, less pain. It heals better, but there's more chance of it extending into the rectum. So if we can avoid an episiotomy altogether, then that would be better. And here's how we perform it. We use scissors so we can make sure that we know what's being cut. We don't want to use like a scalpel or something, because then we might injure the baby. And I said that we might need to do an episiotomy if we're applying forceps or vacuum, so why don't we just talk about operative vaginal delivery. That's the use of forceps or vacuum to apply traction to the fetal head during birth. It helps mom basically push the baby out. It helps her. We do not pull babies out. We assist mom in delivering. Forceps can also be used to rotate a fetal head if it's not facing the right way to help it fit. Forceps are curved metal instruments that lock at the center, and only forceps can be used for rotation. We don't want to rotate with a vacuum extractor. Vacuum extractors are used to suction and grasp onto the baby's head while traction is applied. Indications are to shorten the second stage of labor for the well-being of mom or baby or both. Maternal indications may be exhaustion, inability to push effectively anymore, but she also might have a cardiac or a pulmonary issue where you don't want her to really overexert herself too much. Fetal indications would be non-reassuring fetal heart patterns, failure of the presenting part to fully rotate or fully descend into the pelvis. Some contraindications. Of course, we do not want to do this if the C-section is preferable. So in cases where maternal or fetal conditions mandate a rapid birth, so baby's got to come out right now, then we don't want to muck around with forceps or vacuum. We just want to get in there and do a C-section. So if we have severe fetal compromise, acute maternal conditions such as congestive heart failure, pulmonary edema, a high fetal station, any of these would mean the baby needs to come out now and we just need to do a C-section. The main risk is trauma to maternal and fetal tissues. Because of the relative safety of C-section, an attempt at instrumentation is abandoned if the fetal head does not descend easily. Maternal risks are laceration, which we kind of already talked about, and hematoma of the vagina or perineum. Infant could be bruising, ecchymosis of the face, and abrasions on the scalp, facial nerve injury, cephalohematoma, intracranial hemorrhage. The vacuum may also create a little area of edema on the scalp. So some nursing considerations. You may want to, either you or the doctor, place a urinary catheter to make sure that bladder is empty, so that when we put these forceps into the vagina, we don't hit it accidentally and do any damage. We want to assess the fetal heart rate, and any rate below 100, we need to let the doctor know immediately. After birth, assess the mom and infant for trauma. The mom may have vaginal wall lacerations, a hematoma. Bleeding from vaginal lacerations will be a brighter red color than lochia and will be somewhat continuous. A mom with a vaginal wall hematoma or any sort of perineal hematoma will complain of severe, unrelenting pain. This will be pain that's not crampy pain, it's not uncomfortable pain. It's unrelenting, severe pain on her perineum. If she's complaining of that, you really need to rule out a hematoma, because moms can lose a lot of blood into their pelvis without us really seeing anything on the outside. You might also have edema or discoloration of the labia. And once again, cold, on for 20 to 30, off for 30. For the first 12 to 24 hours is very helpful. Infants might have mild bruising on the skin where the forceps was applied. Skin breaks need to be kept clean, and facial asymmetry due to a facial nerve injury need to be reported. Here's a picture of some forceps. As you can see, when both handles are together, there's still a lot of space in between the actual forceps blades, so baby's head is not going to get squished like a grape if forceps are applied. And here's how they're placed on the baby's head. Here's a picture of a type of vacuum extractor. There's more than one type, but they all have some sort of suction pump apparatus and a cup that's placed on the baby's head to help with the traction, to help the baby out. The vacuum only fits on the occiput because that's how the actual cup is formed. So if the baby has a brow or a face presentation, the vacuum is not going to work. We're going to have to go to forceps. And the last form of operative delivery is a C-section. Some indications for a C-section are dystocia, cephalopelvic disproportion, so that means the head is disproportionately bigger than the pelvis and isn't going to fit. Severe hypertension, maternal disease such as diabetes, heart disease, things like cervical cancer if labor is not advised, active genital herpes, previous uterine surgery such as a classical C-section incision, persistent non-reassuring fetal heart rate patterns or prolapsed umbilical cord, fetal malpresentation, placenta previa, abruptoplacenta. Lots of reasons. Contraindications, there's only one real contraindication, and that's fetal death or a fetus that's too mature to survive outside. So if we have a case where this pregnancy has to end, we wouldn't do a C-section. We wouldn't risk putting a scar on mom's uterus and set her up for bleeding and infection if the baby's not going to survive anyway. Risks to the mom include infection, hemorrhage, urinary tract infection, thrombophlebitis, paralytic ileus, atelectasis, anesthesia complications. This is definitely a major surgery, and all the risks that go along with having surgery are we can apply to this. It's common, and so because it's common, we think that it's routine, and it's definitely not. There's fetal risks, inadvertent preterm birth if we think baby's further along than he is, transient tachypnea, persistent pulmonary hypertension, injuries such as lacerations. We are using a scalpel in this instance, and maybe we accidentally nicked the baby, or bruising or other trauma. Pre-op care is outlined on page 464, so you might want to take a look at that, and post-op care is outlined on 465. So here are some pictures of a C-section. The patient is usually awake, and there's a drape separating where she is, the non-sterile area, from the sterile area where they're going to do the procedure. The partner, if they're present in the C-section, will be behind the drape next to mom's head with her. Here's the sterile field, the part in front of the drape, and the physicians are making the incision in this picture here. Uterus is very vascular, as you can see. Lots of bleeding. Here the baby's head is emerging. That's the head right there next to the doctor's gloved hand. And here's the baby's body. They dry the baby, suction the mouth and nose. If the baby is stable, then they'll let mom hold the baby on her chest back behind the drape while they're sewing her back together. If the baby's not stable, then they'll have to be taken to the pediatric provider. So now we're going to move on to TOLAC and VBAC. Trial of labor and vaginal birth after cesarean. So who's a candidate for a trial of labor? Those moms who have had 1 or 2 low transverse uterine incisions, no more than that, have no history of previous uterine rupture, adequate pelvic size, and there must be an availability for an emergency delivery, so they have to have C-section personnel in-house so that they can rush back to a C-section if they need to in order to do a trial of labor. Moms may get an epidural. They can be induced or augmented with oxytocin, but we wouldn't want to give them Cytotec or Cervidil because it increases the risk of uterine rupture. If we need to ripen their cervix, then we'll use some sort of mechanical dilator like we talked about, the balloon. And we would monitor moms continuously. Risks include hemorrhage, uterine rupture, infection, damage to internal organs, increased risk of thrombophlebitis, increased risk of hysterectomy or death. Once again, very few things that we do to these women is completely benign. And C-section should be limited to those pregnancies only where vaginal birth is not recommended. Because this is what we want, a healthy, happy baby. If we have to do a C-section to get him, then that's fine, but ideally we'd like a vaginal birth, but not at the extent of his safety. His or her, I don't know why I called it a boy. Oh, I can't even tell from this picture what he is, but moving on. So now we're going to cover some psych issues briefly. You can look on page 279 and 280 in your textbook for more of an in-depth information about these disorders, but we're going to start with depression. In order to say that you have depression, then they must have at least 5 major signs present every day, and those major signs include depressed mood, spontaneous crying, marked diminished interest in activities, insomnia or hypersomnia, weight changes up or down, psychomotor retardation or agitation, fatigue, loss of energy, feelings of worthlessness, inappropriate guilt, decreased concentration, or any suicidal ideations with or without a plan. Some meds, there's no real consensus as to whether meds should be given to pregnant women or not. Some say that if you don't need them, you shouldn't take them because she's pregnant. Others say that it's okay. But we do know that if there's a risk of suicide, mom should stay on her meds. Meds like Elavil, Tofranil are category D drugs, which means that there's positive evidence of risk of fetal malformation, so these should be avoided. And these patients also need counseling along with their meds. Patients can also suffer from mood disorders like generalized anxiety, panic attacks, OCD, PTSD. These are not uncommon, but they are disabling because they make mom very uncomfortable during labor. That generalized anxiety, she feels like something is wrong all the time. And they can have panic attacks where they have this feelings of terror, and they can have symptoms like chest pain, shortness of breath, weakness, faintness, dizziness, which could also mimic the signs of a serious condition. So we want to make sure that we know what's going on. These feelings can be recurrent and persistent, and these intrusive thoughts can really cause her lots of anxiety, and we know what anxiety does to moms in labor. Moms try to control these feelings by performing repetitive behaviors like checking and rechecking to make sure the stove is off, for example. That's that obsessive compulsive disorder. Treatment includes antidepressants, cognitive behavioral therapy, and education about her illness. Patients may go on mood stabilizers before pregnancy and are considered, and some might consider staying on them during pregnancy, but that's decided on an individual basis. Some examples of anxiety disorders, as we talked about, are obsessive compulsive disorder and post-traumatic stress disorder, where patients re-experience traumatic events and they work to persistently avoid stimuli, which can lead to these panic attacks. They have difficulty sleeping, they may be irritable, have angry outbursts, they might have difficulty concentrating, they might be very hypervigilant with an exaggerated startle reflex. If PTSD is due to a rape, this can be very hard for moms in labor, where we're doing lots of things down there between her legs. So it's hard for her to kind of avoid that stimuli that makes these visions reoccur. So things that we can do is let mom control her own exams. Try to have female attendants if possible. Mom might also benefit from some counseling and therapy and a referral to a support group. Schizophrenia. This is not all that common, and I'm not going to spend a whole lot of time talking about it. I just wanted to let you know that it's difficult to treat because very, very, very few meds are safe in pregnancy. Most of them cause severe congenital anomalies. So overall, care involves calm, caring, compassionate, non-judgmental care, reduce stimuli, provide consistency in care providers if possible, because they get used to someone and then they become comfortable, help patients identify coping mechanisms that have worked in the past, reduce identified sources of stress, acknowledge her fear, even though it's not real to us, it's very real to them. Repeatedly orient her to where she is and what's going on. She's not in that stressful environment. She's here with us, so she's safe. Provide relaxation and comfort methods. Teach her about what's going on. Be clear and succinct, and provide frequent and therapeutic interventions. So meds to avoid during pregnancy are benzodiazepines and lithium, Tegretol, Neurontin, and Depakote. They can all cause teratogenic effects, which basically means that they'll have severe birth defects. If a mom is on benzodiazepine, though, it can't be stopped abruptly. It has to be tapered off. So ideally, if she's planning on getting pregnant, then she would come in and we would start this process before she conceived. So now we're going to move on to perinatal loss. Unfortunately, not all pregnancies end happily. If a baby has died in utero, then we want to identify this and get the baby out, because as the fetus starts to decompose, the mom is at risk for infection and DIC. Some ways that we can tell if a baby has died is if the mom tells us that she no longer feels any fetal movement or kicks. Some objective findings are no cardiac activity when we look at the baby under an ultrasound. So what do? Well, we can wait for labor, which will usually happen within 2 weeks, or we can induce labor, depending on when a baby is passed. Most providers will let the mom decide, what she's most comfortable with. Some moms want the baby out immediately, and some are not ready to part with them yet. What nurses can do is support and comfort the parents. Many nurses try to avoid these patients. We like to tell ourselves that we're leaving them alone to grieve, but really it's that many of us are uncomfortable with death. If you have a patient like this, these moms need you more, not less, than your other patients. They will have lots and lots of questions. This is not a scenario that they ever imagined for themselves. They'll need lots of encouragement to help them move through their grieving. They'll be angry and scared. You can do things like ask about their spiritual beliefs. Is there anything that they need to have? They want you to call a chaplain. You can provide them with information and guidance as to what will happen in the delivery, and let them stay with their baby and hold their baby as long as they want. Offer to take pictures of them, because once their baby leaves and goes to the morgue and then off to the funeral home, or maybe down to pathology, they won't see their baby again. So let them bathe their baby, dress their baby, name their baby, support and reassure them that these actions and these preferences are not strange or wrong. Parents will want to hold their baby, but they'll be afraid about what you'll think of that. Encourage parents to express their emotion and help them understand that they may not both be feeling the same thing at the same time, and they need to be patient with each other. Dads may feel anger, whereas mom may feel guilt or sadness. Prepare them for what the baby's going to look like at whatever particular gestational age that they're at. If you have pictures available, then show them, because they might not know what a 28-week baby looks like, and they might be shocked that it doesn't look like a regular baby. As I said, take lots of pictures. Babies who have died usually don't have normal coloring, so try to take some in a black and white. Those usually come out better. Take pictures with little stuffed animals and toys that the parents have brought, or take pictures in the outfit that they brought. Take enough for parents and grandparents. You also might get some footprints or some handprints, or if the baby has hair, then cut a little lock off for the mom and dad to keep. And put the hair and the pictures and the clothing and all of that together in a memory box, so that the parents will have something to remember their baby by. So here are some pictures. Here's an example of a black and white one that I was talking about. We try to make the babies look as normal as possible. So if the baby has beautiful formed hands or feet, maybe we want to get a picture of those, but maybe the head might be a little bit malformed. Or if the head is malformed, then maybe put a hat on the head. something to make the baby look as normal as possible, and get hand and foot prints if you're able. Here's some more pictures. Parents might opt to send out a birth announcement just as they would normally. And you can see that baby is there with a little stuffed Tigger. And here's some more. We want to help the parents actualize this birth. We want to use honesty and tell them it's okay to grieve. The mom might be very sad and the dad might be very stoic, wanting to stay strong, but he needs to know that it's okay to feel sadness as well. If the baby has a name, then use the baby's name. Treat the baby as if he or she were alive. That will make the parents most appreciative. And don't rush the family who's spending time. Let them keep their baby as long as they want. We kind of already talked about this, because this is going to be the only time that they have. If they want an autopsy, then be sure to tell the doctor, because if there's a doctor's order, there's usually no charge. And put them in contact with some services out in the community to help them deal with their loss, because we see them for a very short period of time while they're in the hospital. Losing a child is not something that they're going to get through overnight, and they're going to need some help once they leave the hospital to continue on with their grieving process. Most parents whose babies have died, most moms still have physical needs. They did just deliver a baby. They're still bleeding, they're still in pain, so they'll still need to be taken care of. Their milk might actually come in, so we need to tell them what they can do to restrict their milk supply. Offer them a room off of the postpartum unit if one is available, so they won't have to hear babies crying all times of the day and night. Encourage the couple to communicate. Losing a child is very, very hard, probably one of the hardest things a couple can go through. And be sure to address the spiritual needs of the family if you're able. Follow up. There's usually some sort of prenatal demise program at the hospital, and there's someone who's responsible for calling, at 1 month out, at 6 months out, at 12 months out, calling around Christmas, calling on what would have been baby's first birthday, just to check on them and make sure they're okay. And also, don't forget about the grandparents. They grieve for themselves. They grieve themselves for their grandchild, but they also grieve for their child. And don't forget about the siblings. For young children, don't say words like, we lost the baby, or the baby went to sleep, because they take these words very literally, and they might not grasp that death is permanent. They might think, well, baby's lost, we have to go find them. Or school age might be very intrigued with the physiologic aspects of what happened to the baby, so they might ask lots of questions. Be honest, but don't give too much information. That might be overwhelming. These families make everyone nervous because everyone's afraid they're going to say something to upset the parents more. And I can almost promise you that there's nothing you can do to make them any more upset than they already are. But there are a few things that you want to avoid saying, like, this is for the best. That's not anything that any parent wants to hear. God knows who to give these situations to, or this happened according to God's will. Don't say that. We don't know what the parents' spiritual beliefs are, and if you believe that everything happens according to God's plan, then that's fine, but you don't have to say that to the parents. Other things are, someday you'll understand, don't worry, you can always have other children. I have 2 children, and I can tell you, one does not replace the other. You know, there isn't anything that you can do to replace the one that's died. Or you can have other children. None of these things are very helpful. They're meant to be helpful, and people are meaning to try to make the mom feel better, but really they're not very helpful. Sometimes moms know already that their baby is going to either be born and has died, or is going to die very soon after birth if they know that there's a chromosomal abnormality or something like that they've detected early on. Or if they're carrying twins, they might already know that one has died. So that might be, they might grieve a little bit differently than someone who's kind of surprised, and you're seeing them when the initial shock has just hit them. Keep in mind that adolescents grieve differently. So if you have an adolescent mom, don't be surprised if she behaves differently when faced with the loss as someone that's older. Also, we have been talking about fetal death, but moms grieve in other situations as well. For example, if she's giving her baby up for adoption, she may grieve the loss of that baby and will need additional support from us. So in conclusion, we've reviewed many things: premature rupture of membranes, premature delivery, post-term delivery, infection. Didn't change. Okay, sorry about that. I didn't change the slide. So in conclusion, we've reviewed many things: premature delivery, rupture of membranes, post-term delivery, infection, multiples, oligo, hydramnios, polyhydramnios, prolapsed cord, dysfunctional labor, malpresentation, version, macrosomia, shoulder dystocia, uterine rupture, perineal lacerations, induction of labor, amnioinfusion, episiotomy, operative vaginal deliveries, C-sections, mood disorders, and fetal demise. That is an incredible list, and my throat is very dry from all this talking. As you can see, there's lots of things that can go wrong during pregnancy, labor, and birth. So how wonderful is it that most of the time everything turns out great? But we always have to be prepared, so it's very important that we understand what can happen, so hopefully we can work to prevent it. Thank you very much for your attention.